Hi, everyone. Thanks for joining us this evening. We have a great presentation by Dr. Ryan Judy, our hand and wrist surgeon here at Rothman Orthopaedics on trigger finger. Dr. Judy recently joined Rothman, and he is seeing patients at our Chalfont and Willow Grove offices. I'll let him tell you a little bit about himself. During the presentation, if you have any questions, please feel free to enter them at the Q&A box in the bottom of your screen, and Dr. Judy will take as much time as he can at the end to answer as many as possible. You can take it from here, Dr. Judy.
Awesome. Thanks, Natalie. Good afternoon. First of all, I appreciate you all being here. I know it's not the easiest thing to be here 4:30 on a Monday, but I appreciate your time. Hopefully, we can decode trigger finger for you, which is one of the most common reasons that patients come to see a hand surgeon, and certainly one of the most common that they come to see me in clinic. So the name of this talk is Trigger Finger Explained, Relief and Recovery Made Hopefully Simple. I am new to the practice, so a bit about me first. I am originally from Bryn Mawr, Pennsylvania. Went to high school locally in the city at St. Joseph's Prep. I then went to Massachusetts for undergraduate, where I went to the College of the Holy Cross. Came back to Pennsylvania, where I did medical school at the University of Pittsburgh, and then came back to Philadelphia at Temple University, where I did my residency. And then I did fellowship in hand and upper extremity at the Philadelphia Hand and Shoulder Center. As I said, I'm originally from Delaware County, from Bryn Mawr, Pennsylvania. When I'm not working, you can find me spending time with my wife and 5 children. They're aged 7, 5, 3, and I have twins that are 2 months old as well. So I don't have a lot of free time, but on the occasion that I do, some things I enjoy is I enjoy gardening. For the last few years, I've been growing my own vegetables and herbs, and it kind of brings me great joy cooking with and eating with the food that I grew in my backyard. So hopefully I can kind of expand what I've been doing in the next few years. I also enjoy home brewing. For almost a decade, I've been making mead, which is a fermented drink made from honey. I make a couple batches a year and mostly just kind of give it out to friends and families during the holidays. So that's been a lot of fun. And then lastly, I'm a big football fan. My parents are originally from Pittsburgh, and I was raised a Steelers fan. And I lived there for 4 years. I went to school there, so I was raised and continue to be a Steelers fan. That being said, it is very hard not to enjoy the Eagles, and I'm a big fan of them as well. Growing up, maybe it was easier to be a Steelers fan, but the Eagles do play some pretty impressive football. So the only time that I cheer against the Eagles is when they play the Steelers. I see patients in Chalfont and Willow Grove. I perform surgery at New Britain Surgery Center and also at the Doylestown Surgery Center. And I also take call and I am on staff at Abington Memorial Hospital. Some of the most common conditions that I treat, this list is certainly not exhaustive, but I'm really happy to see you for any issue related to your upper extremity. I treat carpal tunnel syndrome, cubital tunnel syndrome, which is compression of the ulnar nerve at the elbow. I see patients with distal radius fractures, really any fractures in their hand. I fix nerve injuries. I see patients with ligament injuries. I treat forearm and elbow fractures. I see patients with wrist tendonitis as well as tennis elbow. And some of the most common surgeries I perform are carpal tunnel release. I prefer to perform this endoscopically. So as opposed to open carpal tunnel syndrome with endoscopic surgery, I don't have to cut through multiple soft tissue layers to get to the carpal tunnel. Instead, I make a very small incision, a hole at the bottom of the wrist, and then I stick a camera in the carpal tunnel itself, and then I cut the ligament that compresses the nerve from inside out. So some benefits to performing surgery this way is it's a much smaller incision and a quicker return to work and sport. I also perform cubital tunnel release. I do nerve repairs, tendon transfers. I do wrist arthroscopy, which is when you stick a camera in the wrist and then kind of treat any pathology that's necessary. I fix broken bones within the forearm, hand, and wrist. I excise ganglions. And then lastly, what we're all here for today is I perform trigger finger release surgeries. So in terms of what we're going to go over today, we'll discuss the form and function of a tendon because that's at the heart of trigger fingers. We'll discuss what causes a trigger finger. We'll talk about the different symptoms, what patients come in with, how we diagnose trigger finger, different treatment options, and then what to expect if you're having either a trigger finger corticosteroid injection or a trigger finger release surgery. All right, so let's get into the cool stuff. Some basic flexor tendon anatomy. So each of your fingers has two tendons. There is one tendon that goes to the thumb that bends that joint, and occasionally there's one tendon to the small finger. So in each of your fingers and forearms, you have what's called the flexor digitorum superficialis, and that bends your knuckle closest to the elbow. So that's this knuckle right here. And then on the other end, the knuckle that's closest to your fingernail, this guy, what bends that is the flexor digitorum profundus. About 7% of the time, the tendon that bends the proximal knuckle, this one, to your small finger, that one's absent. So some people just have the one that bends this. But overall, those are the tendons that bend your fingers. You have two in each. And then within the fingers, surrounding these tendons, there's a series of 8 pulleys. So the tendons connect muscle to your bone. And in your hands, the tendons ultimately attach to the bone to bend the digits. They're really not, the tendons aren't just really loosely flailing underneath the skin. You can kind of see your tendons in your forearm, and they can be quite superficial. But once you get down to your fingers, they're very well adhered and they're fixed tightly to the bone with this flexor tendon pulley system. So what do these pulleys do? Well, they prevent bowstringing of tendons when you bend your fingers. And they also keep the flexor tendon sheath nice and taut so that it doesn't collapse during digit flexion and extension. And at the heart of the trigger finger problem is this A1 pulley right here. And on your hand, that's located right here over your metacarpal head, right over the bottom part of that knuckle. All right, so why do we care? What's the function of the pulley system and why are we talking about it? Well, here you can see the pulleys and how they are a series of tight bands that wrap around the bone and they hold the flexor tendons tightly adherent to the bone so that when you squeeze your muscles, the tendons that go down to the end of your fingers, they pull the bone through the joints, across the joints, and then ultimately bend your fingers. And here on the right, you can see what happens without pulleys or with an injury to a pulley, which is common in rock climbers. Rock climbers sometimes pop their pulleys when they're rock climbing because of their extreme pressures. But without that pulley, you get bowstringing, and really you lose your biomechanical efficiency to bend your finger. So that's the reason that we have all these pulleys in the first place. And this is an analogy that I like to tell my patients about how pulleys work to facilitate finger flexion. So I like to tell them that you can think of their tendons and their pulleys as a fishing rod and this fishing line here. So here you can see that this tendon is the fishing line and the blue little eyelets on the fishing rod, those are the pulleys. Without the pulleys, the fishing line would really not be held tightly adherent to the pole. And without the pulleys, the fishing line would really just kind of make a big loop and it would bowstring. And it would be much more difficult to wind that fishing line up. And that's exactly what the pulleys do in our fingers. They prevent bowstring to maintain tendon excursion and really to maximize finger flexion. All right, so now that we know how tendons work, now that we know how the pulley system functions, let's talk about the pathophysiology of trigger fingers. What exactly causes it? Well, like I discussed before, that thickened A1 pulley is the culprit in all this. So for whatever reason, that A1 pulley undergoes what we call fibrocartilaginous metaplasia. And that basically just means it gets thicker. We're not really sure what causes this. There's some loose associations in terms of different medical conditions and orthopedic conditions that are associated with trigger fingers, but we're not entirely sure what causes this. Regardless, what happens is that thickened A1 pulley squeezes around the tendon like a napkin ring. And then it really turns into a mechanical impingement. So it becomes a size volume mismatch. So this volume mismatch is mechanically through the A1 pulley, and the trigger finger is due to mechanical impingement of the flexor tendons as they pass through a narrowed A1 pulley when you flex your fingers, and that's really at the level of the metacarpal head. Some patients actually feel a bump in their finger. That's pretty common. And what that's caused by chronic friction with the tendon at the A1 pulley. And that ultimately forms a reactive intratendinous nodule. So some people with triggered fingers can feel a painful bump right here at the bottom of their finger. And you can feel that snap occasionally when you're flexing and extending your finger. The digit can then click or trigger or lock, whatever you want to call it, as the finger is going from flexion to extension. It's more common that fingers get stuck in flexion than in rare instances in chronic trigger finger, especially in folks older 7 years old. The fingers can get stuck in extension. So this is another analogy that I like to tell my patients. You can think of this A1 pulley as a napkin ring tightly constricting around a fancy napkin. That's what you see here on the right. So on the left, you can see what it actually looks like inside a hand. So you can see that tight A1 pulley, and what it's doing is it is causing the tendon proximally or distally to basically balloon out, like you can see here on that end of that napkin. And you can imagine when you're moving your finger up and down, that bulbous portion of the tendon pops and clicks and triggers as it goes underneath that A1 pulley. And what you feel is the pain of that big bulbous portion traversing the A1 pulley. And that's why you get clicking, and occasionally you can get the finger stuck. A lot of folks have their finger stuck in flexion in the morning, or when they open up their finger, they can get stuck in extension. So, like I said, the exact etiology really isn't fully understood. But ultimately, we say that it's a degenerative condition resulting from general aging, chronic daily use, and possibly coexisting metabolic disorders. Some of the more common orthopedic conditions that's associated with trigger finger is carpal tunnel syndrome. So there's a study that shows approximately 60% of those with trigger finger have electrodiagnostic evidence of carpal tunnel syndrome at their time of presentation. It's also associated with calcific tendonitis, which is what people can get most commonly in their shoulder. That's associated with rotator cuff tears, but you can also get calcific tendonitis within your hand as well. And that's something that we do see on X-ray. It's also associated with rheumatoid arthritis. Most commonly, trigger finger is associated with diabetes. Other medical conditions it's associated with are gout, different renal disorders, amyloidosis, which can affect the heart, and hypothyroidism. In terms of demographics, it's much more common in females than it is in men. There is a bimodal age distribution. I'm not really going to touch on pediatric trigger finger, but suffice it to say that there is a form that children get. It's typically in the thumb, and it's a little bit different pathophysiology altogether, and the surgery is slightly different. But in adults, it most commonly presents in individuals aged 40 to 60. We know that the most common digit it presents in is the thumb and then the ring finger, and then it drops off pretty quickly after that to the middle, little, and index finger. There's a lifetime incidence of approximately 2.2%, and that increases significantly in folks with diabetes. The lifetime incidence of trigger finger in those with insulin-dependent diabetes is approximately 10%. All right, so what does trigger finger feel like? Well, this is how a lot of people wake up in the morning that have trigger finger. Um, Most often, the finger is most symptomatic in the morning. By most symptomatic, I mean painful. So some patients have the triggering that's so severe the digit actually gets locked in flexion, and you have to use your other hand to pry it open. Again, passing that bulbous portion of the tendon through the A1 pulley so that doesn't get stuck. And as a lot of patients have found out, this can be very painful. It's also possible to get your finger stuck in extension so that you can't bend maybe more than 30 degrees. Again, that's more common in elderly patients with a long-standing chronic trigger finger. Some people with early trigger finger, it really doesn't present with any clicking or triggering. They really just have pain centered over the what we call the proximal interphalangeal joint. That's this right here. So even though the A1 pulley is located right here, a lot of people have referred pain to this knuckle. And so they say, Doc, my hand really hurts right here. But then you have them flex their finger down and you feel a nausea right there and you feel clicking or triggering. So it is important to realize that some people, not all people, present with clicking and triggering, and that you can have pain referred to different portions of your finger. So the clinical presentation of trigger finger really varies with the stage of severity. And as it progresses, the symptoms can evolve and become more frequent. Early on, patients just have pain with flexion. They'll have pain over this palmar surface of their joint right here, what we call the metacarpal phalangeal joint. Some patients also will just say they have a lot of pressure down there and it hurts when they're gripping or weight bearing. As it progresses, people will have active triggering, and so their finger will click or pop as they flex or extend it. After that, the finger can get stuck in flexion, and you actually have to require some force to pop open your finger. Ultimately, some patients develop a flexion contracture. So, with chronic inflammation of that pulley where it's constricting on the tendon, it can cause that flexor tendon, the bulbous portion, it can cause that to ultimately shorten. And that results in a little bit of a contracture right there at this knuckle. When the digit is fully extended, that knuckle can be flexed a little bit. Why it's important to recognize that is that there is less success with a steroid injection if you do have a flexion contracture at the proximal interphalangeal joint, and it's a predictor of prolonged postoperative symptoms. This is a classification system that Dr. Green proposed. It's not incredibly useful, but is more so used to characterize the severity of symptoms. So in grade one, what we call pre-triggering, patients will have pain or pressure. They may have a history of catching, but it's not always reliable on physical examination. Oftentimes in this grade one or pre-triggering, patients just have tenderness over the A1 pulley. Like I said before, that's right here over this knuckle. Grade two or active trigger finger, that's when patients have demonstrable catching or clicking, but the patient can actively extend the digit and they don't have to use their other hand to open it. Grade three is when patients have demonstrable catching that requires passive extension or they're unable to flex it because the bulbous portion of the tendon is on the other side of the trigger finger, or is on the other side of the A1 pulley. And then lastly, patients can have a fixed flexion contracture at the joint, like we just talked about, where the finger's bent a little bit even as they're trying to fully extend it. And in those cases, we know that the steroid injections that we offer and the surgery that we offer have a little bit less success. So it's important that patients recognize that early. If you have a little bit of a bend in your finger with clicking, that's what we call, a pretty bad trigger finger. So what are the treatment options? As with most things in hand surgery, we start with the most conservative and then we go up the ladder to surgery. So some people, it really doesn't bother them. They just want to know what it is. So to that end, trigger fingers are not harmful. It's not cancer. It's not going to hurt you. And it's not going to cause any damage to your hand if you ignore it. So there's certainly a small subset of patients that don't want to do anything. They just want to know what the diagnosis is. There is a paper that suggests there's about a 10% resolution if you do nothing in 2 months. However, most people want to do something because it is pretty painful. Granted, that's not everyone. So in some people, we recommend splinting. And what splinting does is it basically just doesn't allow you to flex the finger. So it doesn't treat the etiology. It really just prevents the triggering from ever happening. Some people, that's all they want. They just want to wake up in the morning and have their finger not flex. And the way that we do that is we keep it stuck in extension. Some people ask, can I do therapy for this? Therapy doesn't change the etiology, it doesn't change the inflammation, it doesn't change that fibrocartilaginous metaplasia, and so it's not effective, and we really don't recommend that. The most common conservative treatment option is a corticosteroid injection. So, why do we recommend corticosteroid injections? Well, this is an article from the Journal of Hand Surgery in 2015, and it investigated the success rate of corticosteroid injections for trigger fingers. And what they found was that patients that get a single corticosteroid injection, about 72% of them are completely symptom-free at 1 year. Ultimately, 39% of those patients required a second injection, and the success rate has varied in the literature between about a third and almost three-fifths. So another analogy I like to use with patients with trigger finger is the first injection puts out the fire, but in some instances, you still have those hot embers. And so the second injection puts out those hot embers. Unfortunately, the success rate after the second injection decreases significantly. And so there are some risks to having multiple injections. So we can't just keep injecting you to kingdom come, unfortunately. You can get skin depigmentation, you can get fat atrophy in the hand, and there is a theoretical risk that anytime we inject around the tendon, that a tendon can pop. So to that end, while this is somewhat provider dependent, most hand surgeons recommend less than 3 injections per year. Um, that does come with the caveat, if you're 80, 90 years old and you get one injection that lasts a year, most folks are pretty okay to give you one injection a year to prevent this trigger finger from getting worse. The success rate in insulin-dependent diabetics is actually even lower, and that ranges between 33% to 50%. It's also important that patients with diabetes know that after a steroid injection to their trigger finger, they can have elevations in their blood glucose for up to 3 days. And so, for that reason, in patients who have diabetes and multiple trigger fingers, I'll only inject one trigger finger at a time. Lastly, if you get a corticosteroid injection for a trigger finger, we have to wait at least 2 months after surgery because there is a risk of wound healing and a chance of infection if you inject some steroid and then you do surgery right there. So we have to wait about 2 months for consideration of an open trigger finger release. This is what it looks like if you have a steroid injection for a trigger finger. So first, I'll clean your skin with alcohol, and then I will use ethyl chloride or the free spray just to give you a local anesthetic to the skin right where I inject you. I will inject with 20 units of Kenalog, which is a powerful steroid, and I also inject with 1 milliliter of lidocaine, which is basically what the dentist uses. And that helps with pain control after the injection. So the solution is injected with a needle, a very small needle, 25 gauge needle. I inject it just superficial to the tendon around the area of that A1 pulley. All in all, the injection takes about 10 seconds. Afterwards, I put a Band-Aid on you. You have no restrictions. And patients with diabetes, like I said, really need to keep a very close eye on their blood glucose for about 3 days. Because even just this little amount of a local steroid can cause elevations in your systemic glucose. I tell all my patients that you can expect good results in about 2 days. At maximum, it takes about 10 days. I have had patients where it takes about 10 days for their steroid injection to kick in, and that's totally normal. All right, now let's say that you had the steroid injection, it didn't work, and you do want to proceed with surgery. So I perform an open trigger finger release, which is the gold standard. There's a very low recurrence rate with this surgery, about 1 to 2%. Some surgeons are performing percutaneous needle trigger finger releases in clinic. However, there is a higher incidence of digital nerve injury, and this is an uncommon procedure. There are also people that perform their trigger finger releases endoscopically. However, this is uncommonly performed, and I don't offer these. So let's talk about what your surgical day may look like. There's two options for sedation. I can do it completely under local anesthesia, which is where I just inject you with numbing medication. And then I do the surgery. In that instance, you're wide awake and you're talking to me. Most patients prefer to be lightly sedated under conscious sedation, similar to a colonoscopy. So in that instance, I still will numb up your finger the same way, but the anesthesia department, they'll give you light sedation so that you're breathing all by yourself. You don't have a tube in your throat, but basically you're asleep for the whole surgery. If you go that route, you likely will need medical clearance by your primary care physician prior to proceeding with surgery. You come to the surgery center about an hour beforehand. The procedure takes about 15 minutes. You'll be in recovery post-operatively for about an hour just to make sure that you can drink and you can eat okay. And then you go home. So let's talk about what surgery looks like. So when you have this surgery, I will put a tourniquet on your upper arm, and this essentially makes it a bloodless surgery. Whether or not you elect to have light sedation or just have the surgery performed under local, I still will inject you with about 10 milliliters of a lidocaine. After that, your finger will be pretty numbed up. And then I put a 2 centimeter incision right here over this A1 pulley. I dissect down through your fat and subcutaneous tissue to your flexor tendon sheath. At that point, I'll find the thickened portion of your flexor tendon sheath that we call that A1 pulley. And you can see here on either side of the pulley, there are digital nerves and arteries. So the arteries obviously give the blood flow to your finger, and then the digital nerves, you have one on each side, and that gives the sensation to the end of your finger. So your arteries and nerves are gently pulled aside with retractors like you can see here. And then under direct visualization, I cut that pulley right in the center. At that point, if you have had light sedation, I'll actually have anesthesia wake you up. If you just had the procedure done under local anesthesia, then I'll start barking some orders from the other side of surgery, and I'll actually have you start moving your hand. And what that does for me is it confirms that the pulley is completely cut in half. I look at your tendons moving, and I make sure that there's no triggering. As long as everything looks good, I have anesthesia, then put you back to sleep. I clean your hand. I put a couple of stitches. I'll put you in a sterile soft dressing and an ACE wrap. And then at that point, you're usually awake and talking to me. One common question that I do get is, can I watch the surgery? Uh, and that's a question that I get if this procedure is performed just under local anesthesia. The short answer to that is no. For sterility purposes, I can't have you looking at your wound. But after I cut your A1 pulley right there, if you are awake, and if you would like to, you can certainly peek over the sterile drapes and take a look. I can show you your finger. I can show you your tendons gleaming and glistening and gliding to show that you don't have any clicking. It's actually pretty fun when patients ask for that. Patients tend to like that. So that certainly is an option. At the conclusion of surgery, I can show you my handiwork and put you on a stage that you can see what you're doing. Here is a little warning, I guess. This is a trigger finger surgery being performed on a cadaver. So if you are squeamish, you can look away. It's about 50 seconds, but it's not too bad. But this is a good video that shows the surgical anatomy and technique of a trigger finger release. So here you can see those neurovascular bundles on each side. That was the yellow line. That red outline right there, that's the A1 pulley. The A1 pulley is about a centimeter in length, and again, that's what we cut to prevent you from triggering anymore. So on each side of the digital nerves, those give the sensation to the rest of your finger. That's what I pull to the side. And as long as I keep my dissection in the midline, that really avoids any damage to your neurovascular structures. Here you can see the A1 pulley being cut. I do not use scissors. I use a scalpel, a sharp knife to cut it. I open up the A1 pulley like you can see here, and then underneath that you can see a gorgeous, shiny, happy, healthy flexor tendon. It is uncommon, but sometimes I perform a debridement of the tendons. It's not typically required, but I may employ that if the tendons are excessively scarred or thickened in the case of a long-standing trigger finger. What can you expect post-operatively? Post-operatively for pain, you can just take over-the-counter anti-inflammatory medications and Tylenol. There is overwhelming evidence in the orthopedic literature that opioids post-operatively for smaller surgeries like carpal tunnel surgery or trigger finger surgery can lead to prolonged opiate use. And given our current environment, unfortunately, with the current opioid epidemic, which I have seen a lot of in my training, we know it's really best to avoid prescribing these opioid medications if they're not necessary. And this is a recent study from two of my partners that actually demonstrated patients were more satisfied with their postoperative pain control for smaller surgeries like trigger fingers and carpal tunnel releases using a multimodal pain regimen than they were with a regimen that was exclusively reliant on opiates. And thus, after trigger finger surgery, you really just take over-the-counter anti-inflammatory medications only because this has been shown not to compromise any postoperative pain, and it is now largely considered to be the standard of care throughout our region. After surgery, some patients can experience occasional swelling in their incision. That is normal, and it can take up to 3 months to fully get over. Some patients have scar sensitivity for whatever reason, that takes a little bit longer to get over. After about 2 weeks after surgery, I do recommend patients with a scar sensitivity. They can get lotion, mix it with about water, 1 part lotion, 1 part water, and really just press it into the incision. And that softens up the incision and it relieves any postoperative inflammation from the surgery. Patients that had that contracture prior to surgery that had a very long-standing trigger finger, they can have postoperative stiffness that occasionally requires the use of our therapy colleagues to help out with. Less than 5% patients have clicking with finger flexion postoperatively. This can be caused by a couple of things. It's uncommon, but it can be scar tissue that forms postoperatively. Interestingly, it can also be caused just by the tendons really like finding their new home with their increased volume. And it's just the tendons snapping over each other in a space that they didn't have before, now that they're free and mobilized. So for that, we just watch it. It typically self-resolves by about 3 months. If not, it can be treated quite successfully with a steroid injection. I take your stitches out 2 weeks afterwards. A lot of people ask, when can I go back to work? If you have a light duty job, like a desk job, you really can go back in a couple of days. For instance, my surgery days are Tuesday and Thursday. So if I do your surgery on a Thursday, you take Friday off, take the weekend off, and if you have a desk job where you don't really need to be lifting with your hands too much, your fingers are out after the surgery. Your sterile dressing is just kind of here over your hand. So those patients that want to and need to, they can go back to surgery on a Monday. If you have a heavy duty job and you're lifting things like you're in manual labor, those patients I really recommend don't go back to work between 4 to 6 weeks post-operatively. Driving you can do just within a couple of days post-operatively. So when you see me in clinic after the surgery, you'll have 2 or 3 sutures placed in horizontal mattress fashion, which is this suture configuration that you can see right here. So this is what your hand will look like the first time you come to see me in clinic. I use these horizontal mattress sutures because they heal from the subdermal layer up. They kind of heal from the bottom out. And I like these sutures because they prevent puckering of the skin. And at least in my hands, it provides a reliable watertight closure. After I take these stitches out, the skin can be raised just due to the nature of this stitch, and that's totally normal. That flattens out over about a week. So I take these stitches out at your first postoperative appointment. That's 10 to 14 days afterwards. At that point, you can start to get your hands wet. You can wash your fingers, take a shower, take a bath. So like I said, I'll see you 2 weeks post-operatively. Your bandage will come off, your stitches come out, you can start getting your hand wet. After that, I'll see you in another 4 weeks, so that's 6 weeks post-operatively, just to assess your motion. Like I said, some people with long-standing trigger finger, they will have a little bit of a flexion contracture, they'll have stiffness. So sometimes those people need a little bit of help with therapy just to get their finger straight post-operatively. And if need be, I could continue to see you after that 6 week post-operative appointment. But most people tend to do pretty well, and at that point, I really only need to see you if you're having any problems. So here are some of the most common questions that patients ask me that come with a trigger finger to clinic. So say for instance you have multiple trigger fingers. You come in with a couple fingers clicking and popping. We operate on multiple trigger fingers at once. Yes, I've done 4 at a time. Will you operate on both hands at the same time? No, we only operate on one hand, just due to surgical, logistics in the operating room. How can I prevent a trigger finger? We aren't entirely sure what causes it. Some people say that repetitive jobs with repetitive vibrations can cause it, but really there's nothing you can do to prevent a trigger finger. If you do have diabetes, keeping your A1C low may help with trigger finger symptoms. Is trigger finger a form of arthritis? No, arthritis occurs in the bones. Trigger finger occurs in the tendons and the pulleys, and therefore we consider trigger finger a tendinopathy. And so for that reason, you don't need an x-ray. So people say, do I need an x-ray for a diagnosis? Do I need an ultrasound for a diagnosis? We really only get x-rays or ultrasounds if other diagnoses like arthritis or tumors are considered. Trigger finger is a clinical diagnosis, and so to that end, you do not need an x-ray and ultrasound to diagnose trigger finger. All right. Looks like we're doing pretty good on time. If people have any questions, I am happy to address any of those. And before that, appreciate your time, appreciate you all being here, and look forward to hopefully meeting some of you.
Thanks, Dr. Judy. It was very informative. There are a lot of questions, several questions that are coming in, so I'll read them off to you.
Sure.
Okay, first question. This person said they've had successful surgery on both of their long fingers this year. Now both of their index fingers seem to be triggering on extension, reverse of the flexion triggering on my long fingers. Is
Yeah,
is this also trigger finger? And why are the index fingers acting opposely to the long fingers?
sure. It certainly sounds like this is also trigger finger. Trigger fingers can get stuck and click and pop both in flexion and extension. It depends a little bit on the position of your tendon as well as how long you have had trigger fingers. Fingers that get stuck in extension more commonly have had trigger finger for many, many months, whereas clicking in flexion is more commonly a subacute or an acute presentation. So you can get them stuck in flexion or extension, and we treat it the same regardless.
Thank you. Is trigger finger more common in the dominant slash writing hand?
It is not more common in the dominant hand. It can occur equally in either hand.
Okay. I think you answered this. Do you typically do X-ray or MRI studies as part of the diagnosis prior to
Sure.
surgery? So,
So definitely not an MRI. MRI is overkill for sure. I frequently do get X-rays just as another layer of information. We don't see trigger fingers on X-ray, but I do find it helpful to have that X-ray just in case there is something else going on. A lot of times you can see arthritis in patients with trigger fingers, so it's also good to counsel them and say, "Hey, you have arthritis in this joint. You might not be painful now, but 5, 10 years from now." Just remember that we had this conversation. So I do get x-rays. I don't need them for diagnosis, but I think it only helps me.
massaging and stretching the finger is helpful, or could that aggravate the problem? If it helps, how often can you do it?
It is not going to aggravate it. However, people tend to have a significant amount of pain over that pulley or a tender, painful nodule. And so if you're massaging it and it hurts, just stop. Massaging it is not going to hurt it, but if it makes you feel better, go ahead. But it is not going to aggravate it.
Thank you. Same person said, can the finger splint, Dr. Frederick's original, be used while sleeping?
Yes. Um, Like I said, the splint doesn't change the etiology and the reason that you have this trigger finger. However, trigger fingers hurt most commonly when you're moving the finger. And so if you put a splint on it, you're not going to move it. And so therefore, you're not going to be in any pain. Some people don't like the splint, but absolutely, if the splint makes you happy, it does cut down on your symptoms.
Yeah. What is your experience working with musicians who have had this surgery? Are they able to fully recover function in the finger?
Yes, a small subset of patients, regardless of their profession, can have postoperative complications like scar, tenderness, stiffness. Um, Most musicians, as well as all other professions, are able to get back to their work, their hobbies, and sports after the surgery.
Thank you. This person said, let me see. My brother had trigger finger, but then he broke it many years ago and it healed like that. Can that be fixed? I'm not really sure what they're asking here. If you guys can, if whoever asked that, if you can reword that question, please, for us. Let's see. Can you repeat the post-op restrictions if there are any, in addition to heavy lifting and not wetting the hand?
Yeah. Yeah, I didn't mention that. You can't get your hand wet for 2 weeks after the surgery because you have a bandage on it. Postoperative restrictions, no weight bearing for 2 weeks until I take that bandage off. You can't get it wet. Other than that, your fingers are out. You're able to wiggle your fingers. I mean, you can hold a pen and write after surgery, but it really depends on the things that you're trying to get back to and how heavy duty your occupation is. But in terms of hard and fast, postoperative restrictions, no weight bearing, no getting your incision wet.
Thank you. Is it better to use an ultrasound to administer the steroid shot?
Hmm. That's a really good question. Some people use an ultrasound every single time they inject. Some people never use an ultrasound. An ultrasound is not necessary. I have used an ultrasound to perform this injection. However, any hand surgeon knows where that A1 pulley is located, and you don't need the ultrasound to find it. Some people use the ultrasound to prevent themselves from popping the needle into the tendon. Some people take the needle and they jab it all the way down to bone. So there's a couple different layers that people inject. You can inject straight down to bone. You can inject into the tendon. You can inject more superficially underneath the skin above that A1 pulley. And ultimately, all those injections are equivalent in terms of symptom relief after the injection. So you do not need an ultrasound. However, some people opt to inject under ultrasound.
Thank you. A couple questions about recommendations for like creams or lotions. Like somebody asked about Voltaren. Is it harmful? Is it helpful? Do you recommend it?
I don't think Voltaren gel gets down deep enough to the A1 pulley to decrease the volume of inflammation, which is why we use the injection to get right there. What Voltaren gel can help with is the pain. It's not really going to reverse the inflammation, but it might help with your pain. So there's certainly no downsides to using Voltaren gel or Voltaren cream for trigger finger. But I don't think it's going to reverse the etiology.
Thank you. A couple questions about your thoughts on compression gloves and if they're helpful.
And I don't find them terribly helpful. Every trigger finger is different. So if you're wearing a glove and it helps, sure, help. But compression against a painful soft tissue, um, a painful soft tissue location, to me sounds like it's going to hurt you. It's not going to change the etiology. It's not going to alter the pathophysiology. You're more than welcome to try it, but I don't think it's going to help.
Thank you. Also, a couple questions regarding trigger finger and if they are, could that be related to carpal tunnel?
Yeah. They're approximately 60% of people with trigger finger have electrodiagnostic evidence of carpal tunnel. So they're not related, but they are highly associated together, meaning lots of people with carpal tunnel syndrome have trigger finger, and lots of people have trigger finger have carpal tunnel. So if you have one of those diagnoses, don't be surprised if down the road you develop the other one.
How about with tennis elbow? Because there was a couple questions about that as well. Are they related?
Yeah. Great question. They are not related. Tennis elbow is a little bit more of an overuse injury, as well as inflammation up at some of the tendons that extend your wrist. They are totally different etiologies.
Thank you. Is there a difference between trigger finger and trigger thumb?
Great question. No, they're both caused by inflammation over the A1 pulley over the tendons. Trigger thumbs postoperatively tend to do a little bit better, whether that's because there's only one tendon that flexes that thumb joint, um, or typically our incisions for the trigger thumb are transverse, straight across like this, whereas incisions for trigger finger in the digits are typically longitudinal. So we manage them a little bit differently. Trigger thumbs tend to do a little bit better, but they are the same diagnosis and we manage them the exact same way, whether that be with a steroid injection or surgery.
Thank you. A lot of questions. Just trying to go through them.
Good.
Let's see. Someone asked if your finger can get stuck permanently.
Yes. Yes. Yeah. A long-standing chronic trigger finger, your finger can definitely get stuck in extension or flexion. If that happens, if it gets stuck in flexion, that's obviously very debilitating. And some people consider that a surgical emergency. You go to the OR the same week. My grandfather-in-law has a trigger finger. He's 92. He has a trigger finger that's stuck in extension. I injected him. It did absolutely nothing because it's been like that for years. And he's just like, well, what was the point of that? They can definitely get stuck in extension. Long story short.
Thank you. Can you tear the tendon by forcing your finger to unlock?
No, you cannot tear the tendon by forcing it to unlock. However, it can be exceptionally painful if you have if your trigger finger is stuck in flexion and you pop it open. Um, it can be incredibly, incredibly painful, but you cannot tear your tendon. You can possibly tear the pulley, but you won't tear your tendon.
Thank you. Someone asked, they've had their lymph nodes removed due to cancer. Can the tourniquet be avoided during surgery?
The tourniquet can be avoided for that reason. Typically, we just put the tourniquet lower on your forearm. So usually we place the tourniquet up here, kind of over your biceps. In those instances, we can place it down here on the forearm and place it less tight. So that is a way to get around it.
Thank you. Are there any exercises that you recommend to help reduce symptoms of trigger finger?
There's no exercises that can reduce the symptoms. However, I will say patients with bad trigger finger really don't want to move it. One of the worst things that can happen that I alluded to is this knuckle gets stiff. This is the hardest knuckle to get unstiff in the hand. So if you do have trigger finger, it's important to come in early so that we can give you a steroid injection for a couple of reasons. One, we can fix the trigger finger with an injection in about 70% of people. And two, it relieves your pain so that you can start moving it. Because if you get stuck like this with a little bit of a fixed finger right there, it's really hard to reverse that. So I will say there's no exercises you can do that can make the trigger finger better, but it's very helpful that you keep your range of motion by opening and closing, like with a squeeze ball or something.
Thank you. Someone asked, do you do trigger finger surgery with arthritis surgery?
Yes. We can do a trigger finger surgery with just about any other surgery we're doing in your arm. For instance, we can do multiple trigger fingers at the same time. We frequently do a carpal tunnel and a trigger finger at the same time. We can do a thumb arthritis surgery at the same time as a trigger finger surgery.
Thank you. This person said, no pain now, but will become painful with time. It's only triggered in the morning, so splint at night.
The natural progression for trigger finger is for it to get more severe, and so yes, it likely will get better over time. Um, However, that is not 100% sure, but likely it'll get worse.
Thank you. There's a pretty long question, a little too specific to this person's case. I'll try to sum it up. This person has 64-year-old male, pre-diabetes, had issues for several years, waking with trigger finger. It's not that painful, but rather annoying. Just he was interested on your thoughts on status quo splinting, which you kind of gave, and I can't pronounce this injection, triama.
Triamcinolone.
Yep.
Yeah,
Oh,
sorry.
it's okay.
Splinting can certainly help with your symptoms. However, it's not going to reverse the cause of trigger finger. I inject with Kenalog, which is a very similar steroid to triamcinolone. They both have basically equivalent results.
Yeah. This person said they've had trigger finger for about 1 to 2 years, both middle fingers. Steroid injection did not work on either hand. Are there issues with recovery when you wait to do surgery?
When you wait to do surgery with bad trigger finger, you can have more postoperative stiffness compared to somebody that had surgery for a more acute presentation. However, the other complications like infection, wound pain, that is all the same. But patients that wait to have their trigger finger operated on may have more postoperative stiffness than others.
Thank you. Is trigger finger surgery a permanent solution?
Yes, there is a 1 to 2% recurrence rate after trigger finger surgery, and it is widely regarded as a permanent solution. I have not seen, I can't think of a time that I've seen any surgeon go in to revise when their trigger finger surgeries for ongoing triggering.
Great, thank you. This person said they got symptoms of trigger finger after they had carpal tunnel release surgery. They received one shot 2 years ago. Should they get another shot?
Yeah, no pun intended, it's worth a shot. There are many different things kind of associated with trigger finger, one of them being carpal tunnel. I have also seen post-traumatic trigger finger, like in patients that accidentally hit their finger and end up getting trigger finger. So it's not uncommon for people to have a surgery or an injury and then end up with trigger finger. And we treat that the same as any other idiopathic trigger finger. Best to start with an injection.
Thank you. This person said your presentation showed trigger finger characteristics with the finger bending forward, like towards the palm of the hand. This person had a situation where their right index finger bent backwards, with the finger seemingly in the position of 90 degrees upwards of the back of the hand. Is that also called trigger finger, or is that something else?
If your finger's stuck in extension like this and you have a lot of pain right here, that certainly can be trigger finger. It's less common to have your finger stuck in extension like this than it is to have your finger in flexion, but both of these are presentations of trigger finger, and we treat them the exact same.
Thank you. This person said they've had stiffness several weeks after their third injection. Is that common?
That's not common. And if you have not had success with 3 injections, then we start to think stepping up to the treatment ladder to something like surgery. Some people say if you don't have any success after 2 injections, you should have surgery. So, if you have not had success with 3 injections, I can't imagine a fourth will make it any better.
Thank you. How about soaking your hand in warm water? Could that help symptoms?
Yeah. A lot of people say that they put their hand in warm water or they heat it with a heating pad, and that helps with the symptoms. That is not going to change the reason you have trigger finger, but it certainly may help with the symptoms. And some people have a decent amount of success with that. So you are absolutely not going to hurt yourself if you soak it in warm water. Give it a shot.
Thank you. This person said they've had trigger finger release, and now when she bends her fingers back towards her wrist, the finger that she had surgery on does not flex the same degrees as the other. How come?
Trigger finger can cause stiffness in this knuckle right here. So trigger finger is caused by a tight pulley here, but a lot of times you get stiff at this finger. The best way to prevent that is to recognize to come in early before you get stiff. And also, sometimes after surgery, we recommend you attending occupational or physical therapy with a certified hand therapist because they're really good at getting back your extension.
Thank you. If you have surgery for one trigger finger, does it cause others to occur?
Surgery on trigger finger does not cause other trigger fingers. However, once you get one trigger finger, you are more likely to get other trigger fingers. If you have one trigger finger, the next most commonly involved trigger finger typically is your thumb and then your ring finger. So trigger fingers beget trigger fingers, but surgery does not cause them.
Thank you. Time for maybe one or two more questions here. Thank you for all of your great questions.
You might be
Oh, I'm
muted.
sorry. I'm sorry.
No problem.
Do you recommend scar away sheets to assist in scar reduction post-op?
I'm not sure. I'm not sure entirely of Scaraway, but silicone scar adhesive pads. I don't, maybe that's what Scaraway is. Those absolutely help about a month after surgery to help with scar tissue as well as soften the incision. So those adhesive silicone pads definitely I recommend.
Awesome. Thank you. This person says their trigger finger gets worse during sleep. They often wake up in the middle of the night with the trigger finger worse and more clicking. Is that common and normal?
Yes, that is the most common presentation being a trigger finger that gets stuck at night, especially in the morning. People wake up with it flexed down. And as that happens more frequently, that means it's getting worse and basically your trigger finger is getting tighter. So in those instances, we recommend coming in for an injection and then possibly a discussion of surgery.
Great, thank you. Someone asked about flossing after surgery. Can you dental floss post-op?
Yes, you can dental floss post-op. No issues.
Thank you. All right, let's see, one more. If you suspect that someone who has trigger finger also has carpal tunnel issues, how would you diagnose and treat?
Great question. So the way that we diagnose carpal tunnel syndrome is both on physical examination. People with carpal tunnel syndrome can have weakness with moving their thumb, as well as numbness and tingling in their thumb, index finger, and middle finger. In those instances, we recommend getting electrodiagnostic studies or an EMG, and that basically quantifies how bad your nerve is getting pinched. After that, we can be fully confident that we have a diagnosis of carpal tunnel syndrome. If we are doing a trigger finger release surgery, we can also do a carpal tunnel release surgery at the same surgery. Trigger finger surgery or trigger finger diagnosis is entirely based off of physical examination, but we do like to get electrodiagnostic studies for carpal tunnel syndrome.
Great, thank you. Thanks so much for taking time to answer all of those questions. There were a lot. Sorry if we didn't get to yours. We got to most. Um, Thanks all for joining this evening for Dr. Judy's great presentation. If you have any questions or you would like to schedule an appointment, you can feel free to reach out to me. You all have my email. A couple questions about if we were recording this. We are, and we will be sending it out to everyone who registered, even those who were unable to join tonight. So thank you again. Thanks, Dr. Judy.
Thanks, Natalie. Thanks for your time, and thank you for all you who tuned in. Looking forward to maybe meeting some of you guys in clinic.
Yeah, everyone have a great night. Thank you.
Thanks.